The interesting things about the study is that it's a so-called window design. And what a window means is that there are already available very effective initial therapy options for newly diagnosed patients with myeloma, usually either a quadruplet regimen if you're transplant eligible or if you're transplant ineligible but pretty healthy, or a triplet regimen if you're transplant ineligible and a little bit more, how shall we say, mature, and maybe a little bit frail. In a window, what you do is that you try a new drug in this kind of setting, but because there are excellent standards of care, we set it up so that there had to be very aggressive responses in these patients, or they would come off trial to get the standard of care. So the way that we set it up is that patients after 2 cycles had to have at least a PR, which means at least a 50% reduction in their disease burden. After 4 cycles, they had to have at least a VGPR, which means at least a 90% reduction. And so that was one way that we tried this new drug, but of course, again, wanted to make sure that if there was any evidence that it wasn't working well, that patients could rapidly move over to the standard of care. With the phase 1A and phase 1B. The phase 1A looked at 3 different target dose levels, and then the phase 1B was a dose expansion to get more experience with 2 of those dose levels. And if we want to just jump ahead to the conclusion of the dose finding portion of the study is that a target dose of 200 milligram was what looked like would be recommended for phase 2 testing. And by the way, that's the same dose that was approved by the FDA for linvoseltamab in the relapsed refractory setting. And in terms of adverse events or side effects, we did not see anything unusual compared with the experience in the relapsed refractory setting. There were no actually dose-limiting toxicities and no grade 5 adverse events. Grade 5 means death, so it's always great when everybody does well on the trial. We did see neutropenia in 38%. Neutropenia is a decrease in white blood cells, and about a third of patients had that at grade 3 or 4. That's not an uncommon effect in newly diagnosed patients because, of course, the neutrophils are made in the bone marrow, which is where the myeloma cells are sitting. So if there's a lot of myeloma, it crowds out the normal cells which don't develop like they should. And it isn't unusual to need some growth factor support in that setting. There also was cytokine release syndrome in 44% of patients. All of it was grade 1. Cytokine release is something that is seen when T cells are activated. They release inflammatory proteins, and you can get fever and inflammation. Not unusual, in fact, very typical for all of these drugs, as well as CAR T cells. And there was only one patient with so-called ICANS, which is immune effector cell associated neurotoxicity syndrome. There were infections in 84% of patients. 1/3 were grade 3. Most of those were upper respiratory tract and pneumonia, which again is not unusual. And there were two events of CMV or cytomegalovirus reactivation.